Definition for frozen shoulder. Frozen shoulder, also known as the adhesive capsulitis, which is defined as a condition of uncertain etiology characterized by significant restriction of both active and passive shoulder motion that occurs in the absence of a known intrinsic shoulder disorder. Frozen shoulder occurs when the strong connective tissue surrounding the joint, which is called as shoulder joint capsule, become thick, stiff, and inflamed. The condition that is called frozen shoulder because the more pain that is felt, the less likely the shoulder will be used. Lack of use causes the shoulder capsule to thicken and becomes tight, making the shoulder even more difficult to move, and it is frozen in its position. The etiology of adhesive capsulitis is still unknown, but it is associated with many problems, such as it is divided into primary or secondary. So primary idiopathic frozen shoulder are associated with other diseases and conditions such as diabetes mellitus, which is account for 10 until 36% of diabetic, approximately 2 until 4 times more likely to develop frozen shoulder than general population. So patients with systemic disease such as thyroid disease and Parkinson disease also can develop the frozen shoulder. So secondary adhesive capsulitis associated with shoulder injuries or immobilization. So this patient develop pain from the shoulder pathology leading to reduced movement in the shoulder and thus developing the frozen shoulder. Surgical procedures such as radical neck dissection, neurosurgery, and cardiac surgery can also trigger the frozen shoulder, which is due to particular reparation are bedbound for prolonged period of time. Pathophysiology: the glenohumeral joint capsule ligament become inflamed, usually in non-dominant shoulder, causes the cytokine and other inflammatory molecules are released, and then triggers the local nociceptors, which is pain receptor neurons, and then causes the shoulder pain, which is diffuse throughout the shoulder, severe, worse at night, disabling, and can't sleep on the painful side, which is on the first stage. The time active shoulder joint inflammation will be decreased as post-inflammatory healing, and then local connective tissue scarring will be increases, causes the less inflammatory molecules are released in the shoulder, and then less activation of local nociceptors and causes the shoulder pain to be decreases. And then it is fibrotic scar tissue begin to accumulate within the glenohumeral joint space, causes the volume of the space in the joint capsule declines, and causes the shoulder stiffness increases, which is progressive restriction of the shoulder movement. It is all happen in the second stage. Months later, active shoulder joint inflammation will stop, but post-inflammatory tissue healing creates abundant scar tissue, causes the non-inflammatory molecules are released, no activation of local nociceptors, and no shoulder pain. And then it is also causes the more scar tissue accumulate in the glenohumeral joint space, as well as thickening and contracting the shoulder joint capsule, causes the severe decreasing in the joint space and joint capsule mobility, causes the shoulder stiffness, which is decrease in active and passive range of motion in shoulder. Any movement is mostly scapulothoracic, which is all of this happen in the third stage. Finally, years later, scar tissue in the joint space and capsule will be eventually break down by itself to be replaced by healthy flexible ligaments, causes the joint space and joint capsule mobility are gradually restored, and then causes the shoulder range of motion slowly returns to normal most of the time. It is called spontaneous resolution, self-limited diseases. Phase 1. Freezing 6 weeks until 6 months. The freezing stage is by far the most painful phase of frozen shoulder. At the beginning of this phase, the motion may be slightly restricted, and that is why early frozen shoulder can be misdiagnosed as a problem of rotator cuff. During this phase, the shoulder capsule is inflamed and becomes thick and stiff. As this happens, shoulder movement becomes increasingly difficult and painful. So phase 2, which is frozen 4 months until 6 months, the second of frozen shoulder is known as frozen phase. During this phase, the shoulder is noted stiff. The characteristic examination finding that confirms the diagnosis of frozen shoulder is not only can the patient cannot move shoulder normally, but someone else trying to manipulate the arm also cannot move the shoulder. But in rotator cuff, the patient cannot move the arm, but examiner can. The frozen phase is typically much less painful than the freezing phase, but pain can result from seemingly simple activities. Rotation of the shoulder joint is particularly limited, making activities such as washing hair or reaching the seat belt painful and difficult. Phase 3, which is thawing, between 6 months until 2 years. In this case, the capsule of the shoulder joint has become thickened and stiff, but over time it is gradually loosens. It is important to stretch the shoulder capsule, even allowing for some discomfort, in order to ensure the shoulder joint mobility continues to recover. Not having the extreme pain associated with the freezing of the joint and seeing gradual gains in mobility make this phase tolerable.
Patient with a frozen shoulder clinically present as number 1, an insidious onset with a progressive increase in pain. The pain will initially start at the site of deltoid insertion and at extremes of motion. Then it will become more diffuse, severe, constant, and will interfere with one's sleep. The pain also will begin to decrease until the pain only will be felt on movement. Next, a decreased range of motion for active and passive movement. Patients with a frozen shoulder commonly present with range of motion restriction in a capsular pattern. A capsular pattern is a proportional motion restriction unique to every joint that indicates irritation of the entire joint. The shoulder joint has capsular pattern where external rotation is more limited than abduction, which is more limited than internal rotation. In the case of a frozen shoulder, external rotation is significantly limited when compared to internal rotation and abduction, while abduction and internal rotation were not seen to be different. Another common condition with frozen shoulder is neck pain, mostly derived from overuse of cervical muscle to compensate with the loss of shoulder motion. Patient also will unable to do certain daily activities. Examples of the routine daily activities that are restricted for frozen shoulder patients are: number 1, button a blouse or fastening back clasps of a bra for women. Overhead activities such as taking books off a top shelf, side-to-side movement such as fastening a seat belt, and brushing hair backwards, as it requires an external rotation movement of the shoulder. One of the complications of frozen shoulder is idiopathic frozen shoulder. Idiopathic is a term used when there is an unknown cause. Idiopathic cases account for the majority of patients presenting with onset of shoulder stiffness. Systemic illness such as diabetes, hyperthyroidism, cardiovascular disease, lung disease, Parkinson's disease have all been associated with frozen shoulder syndrome. Diabetes has the most notable association and frozen shoulders may occur in 15% of diabetic patients, particularly those who have been on insulin treatment for greater than 10 years. Post-operative frozen shoulder can occur in up to 13% of the patient after rotator cuff repair. Shoulder surgery for conditions such as rotator cuff tear, proximal humerus fracture, shoulder instability, and arthritis may result in stiffness due to aggressive scar formation during healing process. Prolonged immobilization to protect a surgical repair may also lead to stiffness. For the post-traumatic frozen shoulder, arm or shoulder injury may result in a frozen shoulder from prolonged immobilization and scar formation during tissue healing process. Complications of frozen shoulder: if it is left untreated, it can cause pain in the shoulder, loss of mobility, and reduced range of motion, and muscle at the shoulder joint can be worsened and persist for a long time. For the management of frozen shoulders, axillary nerve injury can happen due to arthroscopic capsular release, especially when performing inferior release near the glenoid rim. Proximal humerus fracture, dislocation, rotator cuff tear, and brachial plexopathy can happen following manipulation with osteoporotic bone. Rupture of the bicep tendon can also happen after shoulder manipulation.
So for lab investigation, it is really needed for the evaluation and assessment for the condition for adhesive capsulitis, and to add things up, if there is any influencing medical conditions that lead to adhesive capsulitis, this test can be used to determine if there is an effect of the influencing the condition towards the frozen shoulder. So the examples of lab investigation that can be used to test on adhesive capsulitis are complete blood cell count, blood glucose, and also C-reactive protein. So as we can see from the picture, from the two pictures there, so this test can be performed through using blood collection through using syringe, and also using a machine type. So as we can see there, from using this from the image, we can see the examples of the from using a syringe and also the machine. So from there we can use this type of method to do this test. So for doctors' managements in terms of conservative methods, one of the methods are using medications. So when using medication to treat patients with adhesive capsulitis, this can promote pain relief and also improve the range of motion of the shoulder. However, this effect is only effective for short-term goals and not effective for long-term goals. So if the treatment plan for the patient is to achieve a long-term goal, it is recommended to use other kinds of interventions other than medications, because this effect is only for short-term. Other than that, using medications can also relieve the inflammation of the shoulder. Based on the images on the slide, we can see that there are two types of medications that the doctors can perform or give to the patients to treat the patients. These are intra-articular glucocorticoids injections and also non-steroidal anti-inflammatory drugs, also known as NSAIDs. So based on the first picture, we can see that the doctor will perform syringe injections towards the glenohumeral joint, in which it has lots of tendons and ligaments there attached there. So by doing this, it can causes the effect just now that I have been explained to occur on the affected site. On the second image, we can see drugs that doctors can give to the patients to treat their adhesive capsulitis, their condition, by orally taking it. Doctors' management for surgical interventions. So there are indications for the doctors to be able to perform surgery to treat patients with adhesive capsulitis. This is because surgical methods are not really required to treat patients with this condition, because as I have explained before, conservative methods are more reliable to treat this kind of condition. So surgical methods will be carried out if the adhesive capsulitis still continues to persist, in which conservative interventions that have been carried out throughout the patient's treatment plan fail to achieve their goals. This also means that the patients, even after their treatment plan, they still suffer from prolonged shoulder pain and also limited range of motion of the shoulder. Another indications for doctor to be able to perform surgery on patients with adhesive capsulitis is if the condition is left untreated for a long period of time. This means that the patients give little care about their conditions of the shoulder. They do not care about the symptoms of adhesive capsulitis, in which they let it untreated for a long period of time. This causes the frozen shoulder, the adhesive capsulitis, to be gradually worsen from time to time, in which requires for doctors to perform surgical interventions to treat the condition. There are two types of surgical interventions, which are manipulation under anesthesia and also arthroscopic capsular release. For manipulation under anesthesia, how it works is the patient will receive anesthesia, which will allow the patient to be unconscious for a period of time and also make the patient feel no pain during treatment. And then the doctors will perform manipulation on the shoulder joint, which the doctors will do movements and stretches on the joint, and this is intended to break up any fibrous and scar tissue to relieve pain and also to improve the range of motion. Based on my research, I found that manipulation under anesthesia comes with risk of humeral fracture, dislocation, and also rotator cuff injuries if it is not well properly performed. So doctors should perform this intervention with good technique and skills. So for arthroscopic capsular release, how it works is the doctor will make a small incision at the shoulder, at the affected shoulder, and then a small camera will be inserted into the shoulder joint. Using the vision provided by the small camera, doctors will be able to see the tight and thickened shoulder capsule inside the joint. This allows the doctor to cut the joint capsule and to allow the joint to have more freedom and mobility. This intervention can also remove any scar tissue that exists in the shoulder joint. And based on my research, study shows that using this intervention, it has low risk of complications than the manipulation under anesthesia. So it is better to perform this type of intervention to treat patients with adhesive capsulitis. So for physiotherapist intervention, first of all is to give patient education. Physiotherapists should explain the process and stages of the condition. There are 3 stages of adhesive capsulitis, which are the freezing stage, the frozen stage, and also the thawing stage. So for the patient's treatment plan, the physiotherapist should provide or promote treatments that gives less or diminished pain to the patient when they perform the treatments. Physiotherapy should also promote functional movements that are pain-free, so they are able to do their functional abilities at home without the fear of feeling the pain. Specifically for adhesive capsulitis patients, the physiotherapy should also inform that during the end of their treatment plan, they might not achieve their full range of motion back. So the benefits of providing patient education towards the patients are: it reduces the frustration, improves patient compliance to the treatments, and also it lessens the fears of patients when performing or undergoing the treatment plan. So after giving patient education, so there are two types of physical therapy that physiotherapists can do, which are passive mobilization and also capsular stretching. I will explain this more after this. So the effects of physical therapy are: it can increase the range of motion of the shoulder joint, it also promotes pain relief, and also restores the functional abilities. So based on the picture that we can see from the slide, so for passive mobilization, the patient will be immobilized on the spleen or any bed. So the physiotherapist will perform passive mobilization on the patient's affected shoulder. So for capsular stretching, we can see from the image that the patient will independently perform these specific exercise or activities, and physiotherapist should educate and teach them how to perform this exercise in a correct technique and skills. So for passive mobilization, again there are two types of mobilization, which are manual posterior capsule stretching and also scapular mobilization. So based on my research, for manual posterior capsule stretching, it mainly increases the capsule flexibility throughout the treatment. However, for scapular mobilization, it increases the scapular mobility. Throughout these passive mobilization techniques, even for both, they should always refer to the Maitland's mobilization and Kelton-Ball mobilization. This can allow physiotherapists to perform the treatment better and can target the affected tissue in the shoulder more precisely and accurately. So based from Dasgan from 2019, the effects for both of these techniques are the same, which are: it can decrease the adhesions, it reforms the collision, and also increase the sliding of fibers. This is for mechanical changes. So Dasgan also stated that both techniques must be performed together throughout the treatment plan to gain higher achievements for the patient to regain back their functional abilities. Last but not least, we will see the examples for capsular stretching. There are lots and lots of other examples and exercises that patients can do during the treatment plan. However, I'm going to talk about only 3 of these. The examples are pendulum stretch, finger walk, and outward rotation stretch of the shoulder joint. So this stretching can also, just like I explained before, can also increase the range of motion for the shoulder. It also promotes pain relief, and yeah, it is very good for a patient to perform these exercises because it is entirely independent towards the patient's dedication and determination. So physiotherapy should always motivate patients to perform their treatment plan, any kind of exercise at home or at the hospital.